Welcome to today's episode of Marvelous Medicine. As you all know, today's topic is anticoagulant therapy. Is it time for precision medicine? The speaker is Dr. Santosh Padmanabhan. He is the professor of cardiovascular genomics and therapeutics, Institute of Cardiovascular and Medical Sciences, University of Glasgow, and consultant physician at the Queen Elizabeth University Hospital, Glasgow. He is also the commissioner at the Commission on Human Medicines, UK Department of Health and Social Care, and holds several other leadership positions. Dr. Santosh did his MBBS and MD medicine from JIPMER Pondicherry, after which he did his PhD from the University of Glasgow. He's a fellow of the Royal College of Physicians, the American Heart Association, the British Irish Hypertension Society, and the British Pharmacological Society. He has over 85 publications in reputed journals and is the recipient of several research grants. He was the lead on a genome-wide analysis of hypertension, which resulted in the discovery of a new gene and pathway for hypertension. Dr. Santosh is on the editorial boards of Hypertension and Journal of Hypertension. He directs the Masters in Precision Medicine course at the University of Glasgow. Welcome, Santosh, and thank you so much for agreeing to do this session on Marvelous Medicine, and welcome second time to Marvelous Medicine.
Thank you.
Joining him will be Clea Dutoy. I hope I got your name right. She's a junior biostatistician at the Institute of Cardiovascular and Medical Sciences at the University of Glasgow. She did her BSc Honours and Integrated Masters in Pharmacology and MSc in Precision Medicine and Pharmacological Innovation from the University of Glasgow. Clea is trained and worked in areas including validating lung biomarkers for idiopathic pulmonary fibrosis, orexin antagonist hypnotic drugs, and pharmacological support of recovery from peripheral nerve injury. She's also involved in clinical trial design, medical regulatory affairs, and a novel machine learning model to classify hypertension from office blood pressure and routine clinical data without ambulatory blood pressure monitoring. Her current areas of research include studying national data in the COVID UK consortium and to assess the impact of cardiovascular drugs on risk of COVID-19. She's also involved in big data and machine learning analysis for precision medicine and is contributing to the design, conduct, and implementation of a pharmacogenomic service within the National Health Service UK. She has a publication on artificial intelligence in healthcare, The Road to Precision Medicine, and one in the press, Transforming Hypertension Care Through the Lens of Planetary Health. Welcome, Clea, to Marvelous Medicine.
Thank you.
Moderating the session will be Dr. N. Shekhar, Senior Consultant and Head of Vascular and Endovascular Surgery at Kaveri Hospitals, Chennai, India. His department is the only one which is recognized by the National Board to conduct a DMB course in vascular surgery in Tamil Nadu. Dr. Shekhar did his MBBS from JIPMER Pondicherry, MS General Surgery from PGI Chandigarh, and MCH in Vascular Surgery from Madras Medical College, and belonged to the first batch. He was awarded the Doctor of Science in 2012 and FRCS Glasgow in 2014. He has one of the largest series of vascular reconstructions in diabetics, Buerger's disease, and in aorta arteritis in India, and has been associated with over 2,500 renal transplants. Other than training most of the vascular surgeons in Tamil Nadu, he has been actively involved in popularizing vascular surgery and creating awareness amongst the public and the medical community in general. He is the founder and past president of the Vascular Society of India. He has published over 40 papers in national and international journals and has contributed chapters in major vascular surgery books. Welcome, Dr. Shekhar, once again to Marvelous Medicine. Thank you for accepting to moderate the session. Santosh and Clea will be talking of the research aspects, and we hope to get a clinical correlation for the Indian setting from you. Over to you, Santosh.
Thank you. I think we'll start off the session with Clea's talk. So Clea will provide a primer on precision medicine, and then I'll follow up with anticoagulant precision medicine. So Clea first.
So if you have a presentation, please share your screen, Clea.
Okay. Can you see my slides? Just checking.
Yes, yes.
Okay, wonderful. Thank you. Thank you for the kind introductions and the opportunity to present. It's a gorgeous sunny day in Glasgow for a change. which is actually quite similar to what you can see on the screen here. So at the start, at the forefront, we've got the spire, which is a part of the Glasgow University campus. And this UFO looking building in the back is a conference center where we host a variety of exciting events, and most recently the COP26 climate conference. So I'm going to start us off with a primer on precision medicine before Professor Sandosh goes on ahead with the anticoagulant discussion. So this diagram here represents the patient journey, and at some point in their lives, patients will develop symptoms, at which point they'll undergo diagnostic tests, and that's this green group here, and they've been indexed or labeled with a disease. So all people labeled with a given disease will be given the same treatment based on current guidelines, and these guidelines are of course based on evidence from randomized controlled trials, which are the gold standard of clinical evidence. But this group does consist of two kinds of people, which are responders and non-responders, and currently we have no way of identifying ahead of time which patients belong in which group. So drugs and drug dosing are decided and adjusted on a trial and error basis. But this concept of variable drug response isn't a novel concept, and we've known this for hundreds of years, as was put quite nicely by Sir William Osler, who was one of the founders of the Johns Hopkins Medical School in the US. And he's basically saying that the variability between patients is what makes the practice of medicine an art rather than a distinct science. And if we could just predict how everybody would respond to their treatment, we would have automated medical practice a long time ago, and we'd just be using robots at this point. But to contextualize this kind of information into the modern day, we can look at numbers that were published in this paper in Nature in 2015. And these 10 drugs here were the highest grossing drugs in the US at the time, with responders in blue and non-responders in red. And we can see that these drugs work in only 1 in 4 to 1 in 25 patients. And what follows is that the remaining 3 in 4 to 24 and 25 will be given a medication that doesn't work for them. And over time, their physicians will have to go through a long trial and error process to find something that does work for these patients who are non-responders. But the big question is, why is this happening? Why are we approving so many drugs that don't actually work in a huge number of patients? And that's because the clinical practice guidelines are driven by evidence from randomized controlled trials, as I mentioned before. And while they are the gold standard of evidence, they only provide us mean or average effect in a population, and they don't inform us on how an individual patient will respond. So we're still stuck with this trial and error approach. And current diagnostic practice is based on a disease taxonomy, which labels patients by their symptoms or the organs involved rather than kind of the underlying molecular mechanisms. But we do know that diseases have multiple and distinct molecular mechanisms and causes and presentations that drive the disease. So diabetes, for example, under the umbrella of diabetes, we've got types 1 and 2, which have very distinct causes and treatments. And similarly, in breast cancer tumors, or breast cancer can be classified based on their expression level of HER2 protein, and HER2 overexpressing patients have dramatically worse outcomes than those who don't express HER2, even though both groups of patients will have breast tumors. But I'll go into more detail on breast cancer a little bit later on in this talk. And then on the contrary, you can have the same mechanism which is involved in multiple diseases, as is seen in the case of cilia defects, which are implicated in diverse conditions. So you can either have a kind of similar group of diseases which have multiple molecular mechanisms, or you have one molecular mechanism which impacts multiple diseases. And we may not realize it, but personalized treatment, which kind of stems from these molecular mechanisms, is already applied in some medical fields, even without the kind of molecular mechanisms that are involved. So a patient with poor vision will go to an optician who will conduct a series of tests to decide on the optimal glasses for that individual. Or a patient may go to an allergy specialist who will run an antibody test to find out what exactly their patient is allergic to, rather than just giving them a blanket diagnosis of kind of general allergy. But these kinds of approaches are very time consuming because they are individualized for each patient. So the question remains of how do we apply precision medicine in a way that justifies the time and effort that it requires and maximizes the benefits for patients and also healthcare providers? Because the wider application of precision medicine does require that we redefine diseases based on the underlying molecular pathway rather than the kind of pathological presentation, and then we can base the treatment on those molecular pathways. And with these concepts in mind, we can now revisit the patient journey diagram. So here's the typical pathway, which is just empirical medicine as it is practiced now. But instead of having to find responders and non-responders through trial and error, as I was talking about before, we could just add another test after the diagnostic test, which will tell us ahead of time which individuals are responders and non-responders. And this is effectively stratified medicine because we're stratifying people into groups or strata. So these responders in the red here would be given the drug, whereas the non-responders in the green would not, and they could be directed to other treatments. And at the same time, then they won't be subjected to the adverse effects from a drug that they're not actually gaining any benefits from. And as we continue to apply the stratifier test, we might find that it actually indicates an underlying molecular pathway of disease, which could then be applied as a diagnostic test, which is shown by this little d here. So that would then split patients into different subgroups who would then obviously get different treatments. So you've got this disease subtype and the index disease. But I should also mention that stratified medicine and personalized or individual medicine are both subtypes of precision medicine. So personalized medicine, as the name indicates, tailors all aspects of the treatment to the individual, while stratified medicine tailors treatments to a group of individuals with similar features. So personalized medicine could be things like CAR T therapy, or even the optician example that I gave earlier, although it's typically used to refer to these kind of more molecular or cell-based therapies. And then compared to personalized medicine, stratified medicine is of course more efficient because it focuses on groups of people. So in a nutshell, precision medicine is personalizing treatment or stratifying treatment to a particular molecular pathway, which is active in an individual or a group of individuals. But there is a problem with this, and that is, how do we define these individuals? And we need tests to define these patients into the groups. And these tests are typically referred to as companion diagnostics because they accompany the drug that is used for treatment. And without the companion diagnostic, the drugs are effectively useless. I mean, they are of course going to be useless for some people, but the whole point of these very specific drugs is to only give them to the people that they will kind of help the most. And then because the drugs have to come with their companion diagnostic, there's a significant health economics aspect because that increases the cost of the treatment. But I'm going to go into that a little bit more later on as well. So now I'd like to contextualize some of these with a couple of examples of drugs and their companion diagnostics. And we can start off with abacavir, which is an antiretroviral drug used to prevent and treat HIV/AIDS. And a proportion of these patients may develop severe and fatal hypersensitivity reactions, which is seen in this image up here. And it was found that people who develop severe hypersensitivity reactions carry a mutation known as HLA-B5701, which is a bit of a mouthful. But it is possible then, if we know that this mutation exists and it's kind of involved in the hypersensitivity reactions, that we can test patients for this mutation and give them an alternative treatment to avoid these reactions. And this was indeed investigated in this PREDICT-1 trial, which results can be seen here. So the orange bar is a control arm where patients were not genotyped or not tested for this mutation, and all of them received abacavir, whereas the yellow bar shows patients who were screened and were or were not given abacavir based on their screening results. And we can see that patients who were screened had far fewer hypersensitivity reactions, and when we look at the immunologically confirmed cases down here, they completely disappeared. So this diagram then shows the progression of this companion diagnostic test, which tested for the HLA-B5701 mutation. And it only took 8 years for it to be adopted into clinical practice, because what had to be shown was that screening these patients was effective and beneficial from a health economics aspect as well, and not only beneficial to the patients. And this is actually currently the most commonly used companion diagnostic treatment. And the theme kind of that arises here, and that you'll see throughout other examples as well, is that you need the companion diagnostic to separate the patients who will benefit most from the drug or who might be at most risk of side effects. And then treatment can be directed from there onwards. So I briefly mentioned breast cancer before, and this is kind of your flagship example of a precision medicine success story. So some breast cancer tumors overexpress this HER2 protein, which is a growth factor receptor on the cell surface. And patients with HER2 positive breast cancer have a more progressive disease and higher risk of metastatic disease and overall worse prognosis. But the good news is that we can measure this HER2 protein overexpression. It can be done with several assays, but the most common one is fluorescent in situ hybridization, or FISH for short. And these two images here at the bottom show how low and high HER2 expression on the cell surface appear in FISH tests. So because we know this, we can then target treatment for HER2 overexpressing breast cancers or cancers in general. So Herceptin or trastuzumab is an anti-HER2 monoclonal antibody drug. And this study here gave breast cancer patients either chemotherapy alone or chemotherapy combined with Herceptin. And what we can see from these two graphs is that patients who were FISH positive, which indicates HER2 overexpression, saw far greater benefit from this combination treatment than chemotherapy alone. But patients who didn't overexpress HER2 had largely similar results. So then, based on this information, we wouldn't have to give all patients Herceptin in combination with chemotherapy, and we could avoid kind of unwanted adverse effects. And then at the same time, target the treatment to those patients who would benefit the most from it. But again, this companion diagnostic test is needed because that will identify the subset of patients who will benefit from adding Herceptin to their chemotherapy. Got a couple of more examples from the oncology field. So as we know, melanoma is a devastatingly destructive skin cancer with a really high mortality, but a subtype of melanomas is marked by this BRAF mutation, specifically BRAF V600. And because this was discovered, it was possible to develop a BRAF inhibitor drug or a whole host of BRAF inhibitor drugs, which would be effective in this specific subtype of melanoma. And the scan on the left here shows tumors following standard ipilimumab therapy. And over a period of some months, I mean, there is some reduction, but nothing too dramatic. But then you compare it to the images on the right-hand side, where we see the effects of BRAF inhibitors, which shows near complete clearance of the tumor in just 15 days, so 2 weeks, which is quite a dramatic difference to the treatment on the left-hand side. So that shows that targeting BRAF inhibitors to patients with the specific BRAF V600 mutation is therefore highly effective. But there is an issue with BRAF treatment, and that is the development of resistance to the drug response over time. But fortunately, when we look at the molecular pathway a little bit closer, we can see that BRAF is at the top here, but downstream of it, you've got MEK, which is also another signaling pathway, and we can target that with MEK inhibitors. So if we combine BRAF and MEK inhibitors into one treatment, which is this blue line here, it leads to significantly improved survival compared to just BRAF or standard therapy, which is the orange line at the bottom. So then this treatment, whether it's just a single BRAF inhibitor or the combination therapy, again, can't be given to the right patients at the right time without first carrying out a test to identify individuals with a BRAF mutation, which is this test kit at the bottom here. So moving on to the second to last example, we can look at chronic myeloid leukemia. So as a subtype of a neoplasm, it's caused by the formation of the Philadelphia chromosome, which is shown here. So this Philadelphia chromosome is the product of translocation of chromosomes 9 and 22, and this translocation places BCR and ABL genes close to one another. So then what follows this is the constitutive activation of the BCR-ABL tyrosine kinase here. And the constitutively active tyrosine kinase can actually be blocked by a drug, which is imatinib or Gleevec, and then that competitively binds to the ATP binding site and the BCR-ABL tyrosine kinase, which is kind of the basis of the effectiveness of this treatment. But again, it's only effective if the Philadelphia chromosome is present. So we can identify patients with the Philadelphia chromosome by carrying out quite simple karyotyping, so just looking at the chromosomes that are present, rather than having to do fancy genotyping in this specific case. And on the right-hand side, you can see the results of this IRIS trial, which showed that Gleevec treatment led to significantly higher survival than standard therapy. And now coming on to my last example, we've got non-small cell lung cancer, which is another great example of adjusting the taxonomy of disease, which is quite similar to the HER2 breast cancer case. So previously, lung cancers were defined histologically, leading to the small cell and non-small cell lung cancer subtypes. But we now know that there are differences in the expression levels of the protein EGFR between patients. And EGFR is the epidermal growth factor receptor. There are, of course, several mutations that are involved which perturb cell signaling pathways. But in this case, we'll be focusing on the EGFR mutation. We've got the drug gefitinib, which specifically targets the EGFR overexpression, and the CT scan on the bottom here shows clearance of the tumor in the left lung following treatment with gefitinib. And again, as we've seen with previous examples, gefitinib is only effective in patients who carry the mutation that causes EGFR overexpression. And these patients are once again identified with a companion diagnostic test. And this figure here just shows a timeline of the development of some cancer therapies. And the reason that I'm flagging this up is to show that the majority of drugs that are now used in our precision medicine solutions, and they come with their own companion diagnostic tests, which identify the patients with tumor subtypes that specific drugs are effective for. Now, finally, there's a couple of things that I want to highlight before I pass you on. So the kind of take-home messages for this part of the talk would be that precision medicine is essentially identifying subgroups of patients who share a molecular mechanism of disease that can be targeted. So you target that with a specific drug for that molecular mechanism. But the companion diagnostic, which identifies these patients, should come as a package with that specific drug, because one is of little use without the other. And then because of that package, there is a significant financial cost attached to precision medicine, especially as it's compared to the traditional trial and error empirical medicine. So while it might benefit the individual patient more to take a more kind of stratified or personalized approach, the cost may not always justify it. So in order to adopt a precision medicine drug, we must be able to demonstrate to a healthcare provider that the package of the companion diagnostic and the drug is both clinically effective and cost effective to implement. So imagine that there's a drug that's off patent and therefore it's more affordable. And if somebody were to develop a companion diagnostic for such a drug now to say, oh, these patients might benefit more, or these specific patients might benefit more from this off patent drug, it may not really be financially viable. But then you take these novel biologic cancer therapies in contrast, which are already from the get-go typically developed together with their companion diagnostic. And in those cases, the significantly higher cost is acceptable and justified, especially when we see the dramatic improvement in survival. But I think I've now left you with a foundational understanding of precision medicine that is required to make the most of the second part of this talk. And I thank you for your attention for this time. So I'm going to stop sharing and pass you on to Professor Sandosh.
Thank you. Can you see my slides?
Yes, sir.
Yep.
Yeah. Okay, thanks. So, so Clea has presented a nice rosy picture of precision medicine, akin to some of the rare sunny days in Glasgow. So my part of this may sound a bit grumpy, but it's reality. So we'll talk about precision medicine for commonly used drugs, i.e. anticoagulants being an example. So what's the proportion of people who would benefit from a precision medicine approach for some of the commonly used drugs that we use for common conditions? And this is a study from the UK Biobank. They looked at just under 500,000 people and just genotyped them. And what you see on the right-hand side of the plot are for different drugs, the proportion of people who carry a pharmacogenetic variant that has an implication on drug dosage. So the orange and yellow bars indicate the proportion. And you see for certain drugs, there's a considerable proportion of individuals who carry a pharmacogenetic variant that has an implication on drug side effects or drug efficacy. So there is a case for pharmacogenetics in clinical practice. So a pharmacological case. The question is, can we replicate the same successes that Clea has shown for cancers to regular day-to-day clinical practice, either in primary care or even in regular medical surgical wards? So that's a question we want to answer, and that's what we are trying to work on and trying to find a cost-effective and acceptable solution. And we'll go through that through a couple of examples. And I've been asked to speak about anticoagulants, so that's what we'll start with. And coincidentally, Warfarin is the flagship pharmacogenetic drug. And the difficulties we have with Warfarin is an exemplar of all the difficulties that we face making a decision on implementing precision medicine. So for anybody in the world, if you're thinking about precision medicine, there are a few points that you need to consider. So let's start with Warfarin. Warfarin, as you know, is is a drug which has a very narrow therapeutic index. So it's useful and extremely effective, but because of this very narrow therapeutic index, you run the risk of severe bleeding if the dose is slightly higher, or you run the risk of increasing the risk of the condition warfarin was intended to prevent or avoid, that is risk of stroke or heart attacks or embolisms. And why is this so? Why can't we get the range, the dosage right? For that, if you look at the warfarin dosage, it ranges from a 5 milligram per week to up to 80 milligrams per week. So the population demonstrates huge variability in response to warfarin. And there is no way to predict who will respond to what dose. If you look at the pharmacology of warfarin, warfarin, as you all know, inhibits vitamin K-dependent clotting factors. But the way it affects vitamin K dependent clotting factors is through an enzyme called vitamin K epoxide reductase, VCORS. And vitamin K epoxide reductase maintains the balance between oxidized vitamin K and reduced vitamin K, and that's important for vitamin K dependent carboxylase, which leads to activation of factors 2, 7, 9, and 10. Now, warfarin blocks vitamin K epoxide reductase, but warfarin is also metabolized by a cytochrome P450 enzyme called CYP2C9. So a combination of, if there are variations in CYP2C9 and vitamin K epoxide reductase, then that will affect the efficacy of warfarin. And there are a lot of genetic variations affecting function of these two enzymes identified. And in 2017, the FDA produced this label on how to dose warfarin by genotype by considering both VCORC1 and the CYP2C9 genetic variants. So this is there in the FDA label. None of us use it. I don't think anybody uses this for dosing warfarin. We prefer to do a trial and error dosing of warfarin. And we expect that majority of the population would fall within the usual range of warfarin. So what's the barrier to applying this genetic algorithm? The problem here is you need the genotype done. And genotyping means you need to send the sample to a lab to give you a reliable readout of these two polymorphisms. That takes time. You need to decide on warfarin pretty quickly in days rather than weeks. And you need to get the genotype, and then you need to fit the genotype into an algorithm or a clinical decision support that will tell you what dose to give. What you need is a point of care test, wherein you can get the genotyping done pretty quickly. And then you also need to, ideally, you'd like a randomized controlled trial to tell you that the whole thing is worth it. So this was the EU PACT trial, which was done, published in 2013, where they developed a point of care test that would genotype both CYP2C9 and VCORC1 within 2 hours. So that means there's no delay in dosing the warfarin. So they did this. They conducted a randomized controlled trial. They were in one arm, they used the genotype-directed algorithm for warfarin dosing, and the other arm was standard care. And they showed, so the primary outcome was the % of time within the therapeutic INR range over a 12-week period. And they showed that there was a significant difference, 67% in the genotyped arm versus 60% in the genotyped arm were within the therapeutic range over the 12-week period. And that was statistically significant. So in a sense, it was good result. This is the graphical representation of that. You see the genotype arm did not show the huge swings in INR compared to the control group, and you had almost a flat INR range across the follow-up period. The control group, there was initial variation, but it's sort of over time it balanced out with the genotype down. Similarly, the time in the therapeutic range was significantly higher in the genotype group compared to the control group. So that was all very good, but not very exciting, mainly because they didn't study hard outcomes. They didn't study bleeds or other outcomes that would make this much stronger. But nevertheless, this was an important trial because this is one of the first randomized controlled trials at this scale using a point of care test to look at the efficacy of warfarin. And following this, there were a few other trials, a few more trials. One is, this is a trial involving patients who are getting an elective hip or knee arthroplasty. And they again genotyped CYP2C9, VCOR-C1, and an additional CYP4F2 polymorphism. And they had a composite of both arms, both ends of the warfarin problems, either bleeding or thrombosis. And they looked at all, and they showed again, they demonstrated that the genotype guided group was safer and in terms of clinical risk compared to the clinically guided treatment. And that was statistically significant. So the science is good. The science is good. It tells you, yes, there is benefit in terms of warfarin if you can genotype them and dose them. When we talk about pharmacogenetics, it's not a one-size-fits-all because the pharmacogenetic variants show considerable population diversity. So you need to look at whether the polymorphism that you're interested in is frequent enough in the population that you're managing. And for the Indian population, I think it's fine. These are reasonably frequent, and lots of people will benefit if you were to conduct a pharmacogenetic screen. Then comes the other problem that we face in precision medicine. That is, you have this drug called warfarin. It's a big problem. It's got narrow therapeutic index and lots of issues with safety. In the UK and the US, we run anticoagulant clinic. It costs a lot of money, but we follow up patients with warfarin, and it's pretty safe. It does the job. It's trial and error. We don't do genotyping. We just bring the patients, do the INR, and dose them and monitor them. But there is a lot of healthcare costs associated with that. And then we build the whole pharmacogenetic paradigm. We got the genotypes, we do the trial, and we show, yeah, it's beneficial. And then comes a new drug, the DOACs, which doesn't have the problems of warfarin. And this is what Clea mentioned about companion diagnostics. So for warfarin therapy, if you were to do a precision medicine approach, you have the genotype and you have to give the drug. Whereas why can't you just give DOACs? And so clinical practice changes. So you may spend a lot of money doing your trials and everything for precision medicine when a new kid on the block comes and upturns all your hard work. So DOACs are now more frequently used for obvious clinical reasons. A couple of trials looked at DOACs and warfarin, and they showed that in the high-risk warfarin groups, DOACs would be beneficial. But these are all secondary analysis of clinical trials. So the story of warfarin is still unclear about using genetics for driving therapy. And I'll come at the end of my discussion, I will tell you why that is so, and what's the solution for that. I'll just go to another example, clopidogrel. It's not an anticoagulant, it's antiplatelet, but it's another important drug, very commonly used. And the problem with clopidogrel is a prodrug. So it's an inactive drug which requires activation by a cytochrome enzyme CYP2C19. And CYP2C19 is again highly variable. There are variations to the enzyme that leads to an inactive CYP2C19, which means if your patient carries a CYP2C19 *2, *3, or *17 genotype, you may give them clopidogrel, but clopidogrel doesn't get activated. So it's as good as not giving them clopidogrel. And clopidogrel is prescribed for patients as secondary prevention for coronary disease or stroke. And these are patients who are actually not getting the antiplatelet drug, and they're at a higher risk of a cardiovascular event. Multiple trials, secondary analysis of various trials have shown that clopidogrel genotype has an impact on coronary disease outcomes. So that's been going on for a while. And then now you get two other drugs, prasugrel and ticagrelor, which bypasses the CYP2C19 pathway, and they don't require CYP2C19 activation. Clopidogrel initially was on patent, so it was expensive, but now it's off patent. Ticagrelor and prasugrel are newer drugs, they're still on patent, so it's more expensive than clopidogrel, but they don't require the genotyping. So what is what? What do you use? Do you do the precision medicine approach, or do you just go away and just use prasugrel or ticagrelor? Obviously, if you look at the on-treatment platelet reactivity, prasugrel and ticagrelor are more effective. They're more higher risk of bleeding compared to clopidogrel, but just mild. Then you need a clinical trial, and this was done recently, published couple of 2020. Taylor PCA was a large randomized controlled trial which looked at CYP2C19 informed antiplatelet therapy with clopidogrel. It was quite a big trial, but unfortunately it missed the primary endpoint. It didn't get enough numbers, but it did show that the benefit was just borderline significant. If they had more events, it would have become significant, but it was 4% versus 5.9% of the major cardiovascular endpoints. Another trial, Popular, again showed similar results. There was a trend towards benefit if you used CYP2C19 genotyping, and there is a point of care test for CYP2C19 genotyping, and then you can use that to dose clopidogrel. But again, these are two stories using the antiplatelet, anticoagulant sort of domain. And the question is, in this bold new era of molecular medicine and precision medicine, how do we implement pharmacogenetics and precision medicine for commonly used drugs in common practice? We know the pharmacology works, but how do we make it worthwhile? The current recommendation for clopidogrel is sort of only very high risk patients, cardiovascular patients who have either a high risk of thrombosis or bleeding should you genotype CYP2C19. There is CYP2C19 has got huge variability by population. Not a problem. In India, it's not absent. It's considerable. So it is useful to genotype if possible. So I'm going to just provide you with an overview of where we are in precision medicine. I mean, the future is precision medicine. We are all moving towards that. We are all moving towards redefining disease based on molecular mechanisms. So the William Farr taxonomy will change to a molecular taxonomy, which means that we will have a more granular understanding of pathology, and we will be able to tailor treatment based on the molecular mechanism. Now, so that is precision medicine's goal, but to reach that, we need to overcome a few obstacles. The first thing is cost. Ultimately, somebody has to pay for the treatment. Now, if you're adding a companion diagnostic, there is an added cost, which has to be borne either by the patient or by the hospital or by the healthcare provider or by the government. Somebody has to pay for it. And if you're looking at commonly used drugs, then this would be a lot of patients are going to be affected, which means a lot of cost. So we need to keep that in mind. So if you're thinking about implementing pharmacogenetics, precision medicine in your hospital, think about the cost effectiveness. As Clea mentioned, sometimes an all-comers approach may be worthwhile by if the drug is off patent and slightly low risk. But one thing to remember is your DNA and your genotype, they do not change over your lifetime. You just have to genotype once. Now, the problem with pharmacogenetics is that for each drug, you have to have a genotype test for each enzyme or for each gene. So it's not really cost effective. But nowadays you have panels. You can genotype 2.5 million polymorphisms in one individual for less than 50 pounds. So genotyping has become cheaper and cheaper, and genotype doesn't change over your lifetime. So it doesn't matter if you have your genotype panel done, connected to the electronic health record system, then that's fine. So whenever a patient is being prescribed drug, you do preemptive pharmacogenetics. You can look up the pharmacogenetic variant and then dose appropriately. And there's no additional cost because there's only a one-off cost for genotyping. But to get that done, you need the genotyping done first and then integrate it to the electronic health record system. But you also need a clinical decision support system to be built, because there is an educational element. There's physician inertia. Physicians do not like to use it's an extra burden on the physician to look up pharmacogenetic variants and try and prescribe. So you need to ease that burden by a clinical decision support system that's integrated into your electronic health records. If that works, then it's cost effective. Then it makes sense. Guidelines. There are huge efforts now. We've given two examples. CPIC is an American effort, and DPWG is the Dutch pharmacogenetic working group. What they're doing is, we can't expect a clinical trial for every drug gene combination. It's not going to be viable. But what they are doing is they are creating physician guidelines on what to do when you find, or when a patient comes to you to say that, oh, I've got this genetic variant. What should a physician do? And so this is evidence-based guidelines they're producing, and they're systematically working through each drug step by step. And you've got guide, it's all free, it's all available. And lots of clinical decision support companies are integrating this into their provisions. So there are microarrays now available which can do pharmacogenetic panels. You do it once, connected. You've got these guidelines that are being developed as we speak. Almost 63 drugs are now covered. Commonly used drugs are covered. So that's the strategy. So it's not about trying to focus on one drug, one gene. I think we need to have a more global approach across the genome, across multiple drugs. And if doing that, you'll benefit more patients without adding an economic burden or financial burden to the patients. And that's something we are trying to do as part of our work in Glasgow. That's what we're doing. We're trying to conduct these large-scale trials, essentially implementation trials, to try and work out what would be the best strategy to implement precision medicine at scale. The examples that Clea mentioned in cancer and HIV, they affect a very small proportion of the population. And these are very high-risk cases. And the genotyping is actually part of the clinical workflow, i.e., you do your biopsy for tumor sequenced, and then and then you just connect the drug to that. So that's part of standard workflow. So it's not an onerous system. Whereas in general primary, secondary care practice for commonly used drugs, it requires these structures to be built before being deployed. So I'll stop there, and I am happy to take some questions. Thank you.
Thank you, Clea and Santosh, and over to you, Dr. Shekhar.
Oh, that was wonderful, actually. You know, I must admit that in India, we're still far away from this because of cost, because of awareness. And as such, I must tell you, even the anticoagulation is not being done properly in India. So we are at the very primitive basic state of healthcare as far as anticoagulation is concerned, we have really not come to the level of thinking of doing a phenotype, pharmacogenomics, and try. Let me just give you the scenario about anticoagulation here. You know, we use that acinocomerol, that acetone, is one drug which is very commonly used along with warfarin. These are the oral drugs that we use. Of course, Novax have come recently, so Novax are also being used quite commonly. The number of times we have seen patients who have had problems in maintaining the INR, like you said, the therapeutic level of INR. Let me give you one classic example of one of my own patients. This lady, postpartum DVT, she was on acetone, and she sat in the commode, and she could not get up from the commode. She got the help to get up from the commode. And what had happened? The entire shape of the commode, there was a huge hematoma in her bumps. When she was straining to pass motion, there was so much of bleeding that had happened, and the pressure of her body on the commode, she developed like that. So, till prior to that, her INR apparently looked normal, was in the therapeutic range. And why did she bleed so much? We really do not know, because she might have taken some other medicines which all interact with warfarin and acetone. These are some of the practical problems that we have here. There are a few questions that I would like to ask you. Is it necessary, is it possible to do all the genome sequence prophylactically for everybody so that we know who is going to require what kind of medicine, at least for the common diseases that we require, which will be cost effective? Something like that you hinted, but is it possible?
Yeah, so so two answers to your questions. The first is, yeah, so I'll start with the second question. Is it possible to genotype? Genotyping is cheap. The question is, you need, everything has a quality check. So you need to get reliable genotyping. Now, the question is, what will you, who will pay for the genotyping? Now, let's say that it's a one-off cost. The one-off cost is, if you genotype everybody at birth, that's good enough, because, or if you sequence everybody, and the UK's vision is that everybody should have the whole genome sequenced. And whole genome sequencing is pretty expensive. It costs huge amounts of money for the bioinformatics and the analysis. But genotyping the genetic variants, which is good enough, about a few million variants, it is doable. It comes to about anywhere between 80 pounds to 140 pounds per person. So it's a big investment upfront. And not all the variants would be useful for that individual. So it's an argument that you can make if the genotyping platform becomes a bit more cheaper and a bit more accessible. Now, if you look at, there are people sending their salivary samples to 23andMe and getting their genetics done. And I suspect that those early adopters would be the ones who will come to you with their genetic thing and say, what should I do with my drugs? And we get some of those patients here. So it's a question that we need to answer by looking at the risk and benefit. The second part of my answer will probably throw some light on this. So you mentioned about India and anticoagulants not being prescribed properly. So going back to the EU PACT trial, and I said that the EU PACT trial was okay. I mean, it was significant, published in the New England Journal. It was quite a great design of a trial. But in terms of clinical implication, it was not very exciting. It did show that INR was maintained and very stable. And the reason I said that is it needs to be, that paper and the results need to be read in context. Where was it done? So that trial was done in the UK and Europe, where we have good anticoagulant service, meaning we don't need genotyping done because our anticoagulant service will take care of warfarin dosing. It's a separate service. Outpatient people go, they get the warfarin, they go in the morning, get the warfarin done, then either the doctor phones or they get the what dose to take. It's very, very efficient. And it's like a well-oiled engine. So that takes care of our problems. Now, in that background, when you do this trial, you're comparing, adding the incremental value of genotyping to standard care, which is a very good anticoagulant service. However, if you had done the study in Africa or India, where you don't have this well-functioning anticoagulant service, I'm pretty sure that we would have shown a dramatic effect. So this is called leapfrogging. Like in India, you leapfrog the landline telephone to mobile phone, and you got more mobile phones than landlines. Similarly, you leapfrog the old system because you've got the new science coming. So there is a case here where pharmacogenetics may actually help the healthcare system more in India than in the Western countries, because we have legacy systems to manage risk. Whereas in India, where you don't have these infrastructure in place for managing, there is a case. So there is a case for doing this, and it will be cost effective. But you need to build the evidence. In theory, yes, and my thinking when I read the paper and all that is exactly the same thing, that it would benefit. And genotyping is a one-off cost. It's not a cost for maintaining a service, salaries and pensions of people managing the INR test you're doing. The net benefit of that is that you will reduce these the type of complication you mentioned. Unexpectedly people getting severe bleeds. So it's a nuanced answer, but I hope I've conveyed the thing that, so genetics is not for the rich countries. It's not just because we are to be frank, we are at the upper end of the scale where it's like a first world problem. We are doing so much science that we don't know. In reality, there could be simple solutions that we can manage. But the problem for us is the simple solutions have already been sorted out with the structures that we have in place. Our primary care system, National Health Service, all those things have minimized risk or unexpected risk reasonably well. We got all the safety nets in place. So on that background, the incremental value of pharmacogenetics may be minimal. So what we are trying to do is to go at the other end and sequence everybody and look for very rare conditions and various other things. So it's a continuum. You look at where you are in the continuum and then make a decision.
No, if the cost is going to be like what you are saying, I'm sure we will be able to do that here, because 100 pounds is not too much. I think
no, the cost is, so, okay, the cost is economies of scale. When I said 140 pounds, that is for a chip, if you just purchase a test alone. But if you are going to go with a contract to the company, Illumina, and say, we did that in the UK, but not for clinicals, for research. We went to the company and said that, okay, we are going to do these large population studies. So Illumina came back to us with the thing that if you can do 1 million tests across multiple countries, we went as a big consortium. We'll give you the whole chip for 15 pounds, 15 pounds per chip. So it's all economies of scale. If you are able to do a single patient is going to be very, very expensive. But if you go with a big contract, you can really bring the cost down.
Santosh, if you have the time, just go through the comments and questions in the chat box.
Sure. Okay, let me just, I'll read out the questions. And will making drugs in various doses, smallest to the highest, make it safer to start? I mean, that is, so the question is whether we provide different concentrations, strengths of the tablets. Yes and no. The problem is it's about, I sit on the commission, I sit on the regulatory agency here, and we look at this. And the way we look at this is about the chances of medication errors. People misreading a 0.5 milligrams to 5 and 5 for 50 and all that. So you get the commonly used standard dosing. And if you require various fractional dosing, then yeah, we would have to discuss with the company, because there is a cost attached to producing all these. So the company has to agree to that. As regulatory agencies, we need to decide on safety. What is the ones, the doses that will not lead to errors? So that's it. So it doesn't. I don't think it will directly impact on efficacy of treatment, or if making things more efficient. The second question is, genotyping and testing specific genes for a particular patient will be costly and difficult to find labs. Yes, I mean, it has to be done at scale. You only gain the benefit if you can go with a large contract with the company, and not hobby groups. There are companies who will do hobby genotyping, tell you that we can test you for various risk factors, nutrigenomics, nothing. All that is of very little individual use. Because the thing you should remember is most of the genetic risk scores and everything are population estimates, not individual level estimates. So you're taking your genotype and then asking people, or the company is trying to tell you that we'll predict your risk, but they're extrapolating a population risk and from European populations, and then extrapolating that to tell you that, oh, you have a high risk of heart attack or stroke or whatever. So it has to be so two things you need to do. One is you have to do it at scale. Secondly, you have to build in evidence generation, because genetics is the property of the population. You cannot extrapolate genetic results from other populations to your population. So if you're doing this, as I mentioned, this one, you need to integrate into your electronic health records and whatever, which means it's an ideal system for you to review the data and pick up new signals.
Sorry to interrupt.
Yeah.
Talking about population, if you're finding something in a particular population, can you make a general statement that this population is going to have? I just want a clarity on that.
So it depends on the allele frequency. It depends on how frequent the allele is in the population. So most of the genetic variants. Okay. So going back to genetics, just to explain this. So genetics, your genetic variation is dependent on evolution. So if you have a variant which is highly detrimental, that's going to be selected out. So that variant becomes rare and rare in the population. Most of the pharmacogenetic variants are not detrimental. They don't kill you per se, because most of the pharmacogenetic enzymes were developed or evolved long ago to protect humans or animals against plant toxins. So against any xenobiotics. That's the purpose of it. Now we are giving drugs, and so these enzymes are acting to detoxify them. So these variants they don't have an impact on reproduction. They don't have an impact on mortality, which means you will have high frequencies of these variants in the population. The question is, how high? Is it majority of the population? Is it a small? And it makes a big difference, because if you have a variant which is 1% in the population, or even 10% in the population, compared to a variant which is 50% in the population, the number of people at risk would be significantly different in the two groups. And within those groups, not everybody will be exposed to the drug that you're interested in. So then the whole thing becomes subgroups upon subgroups. So the target population who would benefit will be the population who have the genotype and require the particular drug. So it's difficult to generalize all this. So if you take what's the example? If you take drugs like if you take anti-malarial drugs and G6PD deficiency. Now, the question there is G6PD deficiency has some protective against malaria. So in African countries, you got higher frequencies of G6PD, which means that a lot of people there will end up with hemolytic anemia. So therein, there is a good case for a population level screening and giving the drug. So you need to make a, which is why for all these things, you need to make a health economic case. And health economic case depends on the people at risk based on genotype and getting the drug.
So why I asked was, no, I think the Vidya can enlighten on that. See, in a group of the caste-based, like Chettiars are supposed to have a cholinesterase deficiency, very high level. So they don't tolerate schooling. Vidya?
Yes, sir.
Yeah. So see, they don't tolerate schooling. So it's like that. Is it possible to make some kind of a prediction that in this particular group, this is going to be there? So you can change your drugs.
Yeah, absolutely. So yeah, absolutely. So what that tells you is that you have a very high frequency, which means a majority of the population, which so it depends on the allele frequency. If the frequency is very high, that means the proportion of the population who do not have the variant is low, but there is no cost implication to screening them. If it was a 10% versus 80% or 70%, if it's a 70% frequency, then yeah, genotype everybody. If it's 10%, then it doesn't make economic sense to genotype everybody when only 10% would be. So for the example you're saying, yes, you genotype them. The other example is, Chinese population, they have high frequency of aldehyde dehydrogenase polymorphism, which makes them sensitive to alcohol. So in general, you can say, though not all of them will carry the variant, but majority of Chinese population carry the variant, which makes them sensitive to alcohol. So yeah, you can make generalizable statements to very specific genetic variants. Okay, the next question is, what pharmacogenetics has been done in rheumatology so far? I can see opportunities for methotrexate. So rheumatology is a big,
No, I was just going to say that what I've seen mostly in rheumatology is kind of against adverse events, rather than maybe picking, at least so far, I haven't seen a whole lot of biologic targeting, but you might know more about that. But I've just seen, in the way that you were talking about the CYP450 enzymes, those can also be applied for things like NSAIDs. But of course, that kind of goes back to what we were talking about before in creating new companion diagnostic tests for drugs that already for drugs that are already off patent. So the incremental benefit might be quite small. So they're kind of just to decrease the toxicity of NSAIDs, or tramadol is quite often as well implicated in the CYP450 enzyme pathways. And then the big one, I guess, would be allopurinol, because you get Stevens-Johnson syndrome, because then that's kind of a similar case as with abacavir. But if you're aware of any more specific targeting, then of course.
Yeah, I think correct. The allopurinol thing is quite a good example, because some of the genetic variants for allopurinol is very population specific. So there are quite a few quite high prevalences in the East Asian population compared to other populations. That is what the other things about. So the question also methotrexate. We have done studies or groups in the UK. We've done a lot of studies, enormous amounts of studies, to see if we could predict methotrexate response or even toxicity, because that's one of the sort of commonly used modifying agents with high risk. We've done. I know of groups who've done a lot of work, not just genetics, looking at gene expression, metabolomics, and everything. Haven't got much. They were looking at a panel, a prediction. You get a gene panel or expression panel that would predict methotrexate toxicity or whatever. We haven't found anything. We haven't found anything that would be that would consistently perform. new bits about rheumatology, new biologics coming in. Again, we haven't got a signal as good an example like we got for cancer. But biologics are it's going to evolve, and we will find something in due course. But currently, it's still in the research stage for rheumatology and tailored therapy. The other question, anticoagulation, we've covered about over or under treating. The dictum in pharma industry is any new generation drug developed becomes more costlier and never cheaper from the parent drug. The benefit to cost is very important. Yeah, absolutely. So as I mentioned, but patents do come to an end. And that's what, and as I say, I've shown you the example with DOACs coming in, they're on patent. Or you do have off-patent older drugs, and you have the newer drugs which are more expensive. But as time passes, that will change. That is life, that's business. Pharma companies won't develop new drugs unless they have a financial incentive. So again, here again comes the question of negotiating. So the UK government negotiates with pharma companies as a country. So they get the cost, but of course they get cheated, and they get they pay a lot more than the true cost of the drug. But it all depends on how that's worked out. For instance, if you look at orphan drugs, these are drugs for orphan diseases. No pharma company until recently were interested in developing drugs for orphan diseases. The reason for that is very few patients will benefit, so they don't get return on investment. What the UK and US government, what they have done is they have created this orphan drug package where they tell the pharma companies, you develop the drug, and for so many years, you can charge whatever you want, and the government will pay for it, which is why we see a huge rise in pharma companies developing orphan drugs. So now it's a government thing. They say that we'll invest in it, we'll pay whatever you want. And we are looking at drugs costing £200,000 per dose. But the government is underwriting all that, mainly because nobody can develop it. Only pharma people can develop these drugs. So to incentivize pharma companies to develop the drugs, the government, the orphan drug process will cover and help these patients with very, very rare diseases actually get a diagnosis and get treatment. So yeah, so that's a big topic. What's your take on elective genotyping in the early part of life? So as I mentioned, genotype doesn't change through your lifetime. We all talk about this in our Brave New Future, which is you get your genotype done at birth. But few cautions there. Your genotype is your own. And the question, the implications there are, do you want to know what your genotype is? The biggest thing we are facing here is if we genotype or sequence somebody and we find there are variants that will cause an incurable disease, do we tell the patient? So this is called return of results. Then we get incidental findings. So if now that we are sequencing a lot of people, what we find is, we find that there are about every one of us will carry about 50 null mutations. So these are mutations that are single gene mutations causing rare syndromes. And we thought that if you have these mutations, you will die at birth, or you'll be with a severe deformity at birth and not survive. But because we are sequencing a lot of people, we now notice that all of us carry rare variants, all of us carry null variants. And that opens up another question. So the question is this: if we carry null variants, and if we were sequenced at birth and told that we have this rare incurable disease, what do we do? What happens to your health insurance? So those are the ethical issues. We don't have a solution yet. There are lots of work going on. And we don't know. We don't have an answer to that. But when I would suggest, and the problem is this: if you genotype everything, and somebody steals your data and uses it for something else in the future. You don't know. This is data. Data can be stolen. Nothing is not secure at all. So what will you do? Are there safeguards in place? Currently, we don't have. We need to build something, and that's still a matter of research. So ideally, yes, genotyping early in life will be good for the future. But there are cautions that we need to look into. Yeah, and the next question was about insurance coverage. Yes, there are, for instance, again, another example is BRCA genotyping. And there are lots of, after Angelina Jolie, a lot of people are getting their mastectomy done by just genotyping. But many of them may not need it. So it become a fashion and lots of people do it. But question is, many of them don't need it. Then there is the other problem here is you do your genotyping. So the two issues. One is you do your genotyping and you find that you have a high risk mutation. But or you got the BRCA mutation or something, and it affects females, but you're a male. The question is, your relatives, do you tell them? Do you, who haven't gone about genotyping, do you want to disclose it to them? And that raises ethical issues, because then there is whole stress, insurance problems, costs, healthcare costs, all those things are going to, and these are real life problems. There are examples of such things happening. And one of the best example is John Watson, the discoverer of the double helix. He did this, one of the first people to get sequenced. And he found that he had BRCA and other things, and big debate about whether he should tell his relatives. And the other question, obviously, is Huntington's. Any incurable disease, which is late onset, means do you want to be stressed about it, reduce your quality of life just because in many years in the future you get an incurable condition, motor neuron disease, or so there are huge ethical problems with doing this type of genotyping, and anybody who's getting their genotyping done should understand the implications. Some of what we do here is when we do research, we tell patients that we won't look at certain regions of your genome, because then we don't have this thing whether to tell you or not what is there. And some patients will say that you can look at it, but don't tell me. I don't care about it, but do not tell me. And so we are still building these safeguards, and we need to be aware of that, especially so when you're doing sequencing. With genotyping, you can always restrict what your genotype. You can only look at what you want and forget about the rest.
No,
but yeah, so
let me ask you, is it really 100% foolproof that if you have a particular mutation, you must have developed that kind of a disease?
No, because disease penetrance is variable. Yeah. Disease penetrance is variable.
That is why it becomes a problem.
Yeah. And that is why, if it was a one-to-one relationship, then it's fine, because you can say, yeah, this is definitely good. But here, the problem is there may be people who may not manifest the disease. And as I told you, the null variants, I will carry 50 high-risk pathogenic variants, which should have killed me at birth. But it's there. Everybody has it, but it's not expressed.
Yeah, this is just like our surgery. You know, when we take a consent, I tell them, if I'm doing a therapy in doctor today, I tell them the chance of developing a stroke during surgery is 3%. Whether you are going to be in this 3 or 97, only God decides. I cannot tell you a guarantee.
Yeah. Okay, the other question is, yeah, clopidogrel and proton pump inhibitor interaction. So that's a nice question. So
Santosh, if I may interrupt, it's a very high relevance in India, because both these drugs are abused, overused and abused, and with quasi indications or whatever. When I go for my pre-anesthetic check, I find both of these in 70% almost of my patients are above 40 or whatever. So it's a very important question.
Yeah. Yeah. So the problem with proton pump inhibitor is that PPIs, especially omeprazole, they mimic CYP2C19 variant. So taking clopidogrel plus omeprazole may actually reduce the efficacy of clopidogrel. Whereas so again, different PPIs have different effects, and omeprazole is bad. I think the newer ones, rabiprazole, is probably has a lower impact on CYP2C19 than the other ones. But yeah, but that it's a phenocopy, so that interaction is pretty important in patients, especially if they do carry the CYP2C19 variant, then you're going to have a double dose effect of PPI on this. Okay, next question. Some diabetics require very high dose insulin, some have very erratic response. Yeah. Insulin, no, we don't have a lot of pharmacogenetics on insulin because there are lots of other factors where you inject your insulin, your lipodystrophy and all this affecting the absorption of insulin. But yes, there is a small subgroup of patients who have very brittle diabetes and very high fluctuations, and those we struggle with. There is no pharmacogenetics yet. There are some pharmacogenetics in relation to metformin. There's some in relation to sulfonylurea. We know that there are certain genetic variants that could predict response to metformin and sulfonylurea. But otherwise, for insulin, no, nothing. Diabetes in pregnancy still, insulin, no, there's nothing we can do. Yeah, then there is allopurinol, methotrexate, azathioprine. Yes. Yeah, so allopurinol, yes, we mentioned there is genetic variance, Stevens-Johnson syndrome, pretty dramatic. Methotrexate, no, methotrexate is also interesting because methotrexate is folic acid. So it depends on what you eat, your diet. If you have your folate, you're going to minimize the effect. So there are genetic variants that affect folic acid metabolism, and that can affect your methotrexate dose. Azathioprine, mercaptopurine, that's TPMT. So thiopurine methyltransferase is the test that you do. And that's very, very, that's a good pharmacogenetic test for drug toxicity. And you can either do a genetic test or you could do there are in vitro tests to detect your TPMT status. Carbamazepine, there are variants, more common in East Asian, Chinese and Japanese population than elsewhere, causing Stevens-Johnson. And phenytoin, again, similar, that there are variants which affect toxicity. So these are all toxicity. And if you look at most of these variants causing toxicity, they are all HLA. So for abacavir, it's HLA-B5701. For all the rest, carbamazepine, phenytoin, valproate, you've all got HLA variants that affect efficacy. And tacrolimus, yeah. So I'm not sure of any. I'm not sure of any variants for tacrolimus. If I remember right, there may be something for mycophenolate, but I'm not sure about tacrolimus. And then Lata asked about pharmacogenetics applicable to obstetrics. So we did I don't know. I mean, there is, we did a lot of genetics of preeclampsia and found a few genes that are linked to preeclampsia. It was quite a difficult study. So other pharmacogenetics, I mean, the problem with obstetrics is that you don't give a lot of toxic drugs in pregnancy. So you're not exposing patients to drugs. And you would be very careful about what drugs you give to pregnant patients. So in a sense, you are minimizing the risk. So the chance of pharmacogenetics would probably be quite minimal in obstetrics, unless you're dealing with life-threatening conditions that you need to do. But then in those scenarios, you won't be waiting for genetics your genetic results to come back. So yes and no. I think the current status, just because you will be extremely careful prescribing to pregnant women, the role of pharmacogenetics may be minimal.
Can I ask something?
Yes, Lata.
Yeah, I mean, I think it's a comment. Our problem is that with obstetrics, we hardly can do any studies, especially a randomized control trial, because everywhere there is a problem. No one allows us to do so. Sometimes, as you said, we are really, really stuck with nothing sometimes. I mean, no drugs act, and it's very difficult
Absolutely.
situation also.
But it's the same here. I mean, women and pregnant women or women in the childbearing age group, we don't do trials. They are excluded from trials. And this is the big problem because we don't have evidence in these high-risk, vulnerable populations. So women in the childbearing age are not part of any major trials. Pregnancy, no trials. Children, no trials. There is now work going on to try and see how we can get evidence in these populations. And one of the things is big data. If you can't do a trial, get large amounts of data and then look into that. Because once you get huge amounts of data, talking about millions of people, you can get some evidence there. So have you or other colleagues faced any lawsuit, or what's the medical legal standing? I mean, we are very careful, mainly because as I say, we have our lots of safety nets in our medical practice, meaning we don't prescribe. We only prescribe drugs in the formulary or anything. And if there is any evidence that something would work, we will do it. The problem for us is mostly these hobby geneticists. They go to 23andMe, do their genotyping and bring us. I have a couple of patients who come and say that I've got cytochrome P450. We can't, I mean, there is, so in terms of pharmacogenetics, we are expecting in the future. Right now, it's still a state of flux. But as I say, we are now building, we are not jumping into this headlong. We are doing trials. We are engaging with the community because most of the reasons for a lawsuit would be ignorance or lack of understanding. So what we are doing is, so we are designing a as Clea mentioned, we are designing a pharmacogenetic trial. But that trial is not us sitting in ivory towers and saying this is how we randomize. We have patient engagement. We bring patients in. We get their viewpoint. We do the trial with a lot of patient and public engagement. We bring all the stakeholders. We bring pharmacists. We bring doctors, all the prescribers who would prescribe drugs. We get them together. We get all feedback from them. And then we design the trial with their input. So it has to be, whatever we do, it has to be acceptable to the patients nowadays. So it's a long-term process, but this is, from bad experience in the past, we have now got certain procedures that we follow when we do trials or when we do new things. So pharmacogenetics will come through. We are going through it the hard way. We're doing it properly because, as I mentioned, there are lots of areas where we can get sued. Like the patient can claim that we didn't tell them the result, or they can claim that we shouldn't have told them the result and we've destroyed their life because we told them the result and things like that. So it's a minefield. So we need to be quite careful that we get the right evidence so that nobody is unnecessarily burdened and we don't give the wrong information that will lead to either cost, both health and mental health and financial.
So there needs to be a lot of counseling before you can, before doing any genetic testing. I suppose there should be, especially when it is not for a specific therapeutic thing like breast cancer or something, you'll need to do a lot of pre-testing counseling, I suppose. So how do you manage that during a trial? That would take a lot of time and effort, right? So
during the trial, we specifically don't look for variants of major diseases. We're only looking for pharmacogenetic. As I said, pharmacogenetic variants are common in the population. They don't have an impact on disease, or they don't have an impact on longevity or survival. They only affect drug metabolism. So for that, we don't need counseling. If you're sequencing for rare diseases, or if you're going to, which also the other thing is that it depends on what you're looking at. The genome is 6 billion letters long. If we look closely, we will find a problem. If you're going to do a study wherein we say that we are going to look at your whole genome, that's problematic. We're going to look only at these variants. It has no impact on your survival. That's fine. That you don't need.
And we typically only look at the ones that are actually like actionable. So say with the kind of liver enzymes, we know that there's a whole bunch of different variants, but a bunch of variants that impact a really important enzyme, but if we don't know how they actually impact drug clearance, we usually don't look at them. So we just look at the drugs, like it's like drug gene pairs, so the genes that are actually demonstrably connected to a drug that would actually impact patient care as we know it at the moment. So we kind of try to also minimize the information that we hold for each patient.
Yeah.
How much have you been able to apply this knowledge towards clinical practice? How many people are really followed? Does everyone do the pharmacogenic study before starting clopidogrel or before starting anticoagulation?
So there are currently there are two ways by which that is done. One is so the commonly used method. When I say commonly used, we are talking about perhaps 5 or 6 health boards in the US and none in the UK. What they do is they do a panel of either 7 or 10 markers and integrate it into the health record systems. Nobody is doing genotyping, reactive genotyping, meaning when you want to prescribe your genotype, nobody is doing that. What they're doing is they are doing, like for instance, if you look at Vanderbilt Hospital in the US, they've invested in genotyping a few 100,000 markers of all the people attending their hospital. So a few 100,000 people, they genotyped all of them and integrated that into their health record system and built a decision support. So whenever a physician tries to prescribe a drug, clopidogrel, it looks up and say, this is thing, give something else. So that is happening in Vanderbilt, and that's called preemptive pharmacogenetics, wherein the genotype is already sitting in your health record system, and it's preempting the doctor. Reactive is complicated. It's very expensive. It takes time. Somebody has to do the genotyping, and genotyping service is not available anywhere. It's available in research labs, but not as part of service. So there are health boards doing that, but as I say, it's a work in progress. We are thinking. In Scotland, we are thinking of doing this, and we are currently in the process of developing CLIA as part of that group. We are developing a framework on what to do for a nationwide rollout of pharmacogenetics. And what that requires is we still need evidence. We need a trial. Have to have evidence. And the evidence is not about one drug, one gene. It's about the whole package, the whole process of pharmacogenetics. And then we need education. We need physician education. We need pharmacist education. We need patient education, because people need to understand. Because there's lots of fake news. So people may think that the genotype that we are using may be detrimental to them, or if so we need to ensure that there is good understanding of what we are doing. And because we are changing treatment, we are trying to, the problem always happens, like this is the other big problem in genetics, is about exclusion. People feel that they are biologically excluded from new treatment. People feel that they are somehow disenfranchised because based on their biology. And this is a huge problem, because only the rich can get genotyped. The poor can't get genotyped. So the rich get benefit, poor don't. So there are these social tensions and everything that we need to cover. So if we have to implement this at scale across the country, that's a government by government policy. The government wants to know that this will be equitable, this will benefit every sections of society, and it won't produce a huge bill to the government. So it cannot be done. So it's a complicated process, and we are now starting on that journey, and it will take about 3-4 years for us to at least do one part of that. But what we are trying to do here is not single gene. We want to do a panel, and England is doing the same thing. They've also made a call recently that pharmacogenetics has to be implemented, and it has to be the panel of a large number of genes and integrate into health record system.
As of now, we've just started doing it for clopidogrel. Especially cardiologists, they're very worried when they put in a stent. So if the clopidogrel is not going to work, they go for prasugrel or something like that. So
yeah,
they have started.
I think,
but it has not become a routine. It's not become a routine.
I think that's I think high-risk patients, clopidogrel genotyping is good because antiplatelet therapy is the mainstay of secondary prevention. It has to work. So so I think that makes good sense. So you're not doing it at scale at everybody, but only selected patients you're offering it, which is good.
Radhakrishna, your take on today's program?
It's a wonderful phenomenon, I should say, that quite thought-provoking, and I'm sure this will come into practice elsewhere in the world, and soon it should catch up in India. My only worry is if gene sequencing becomes a mandatory thing for all of us, and it has to be put on an Aadhaar card. And if it shows that my great-grandfather had an illicit relationship with a Chinese girl, 2 streets away, a century ago, I don't know. I mean, things of that such come out actually. I'm Dr. Santosh might.
It's happening. The bigger problem is
somebody's granduncle unrelated.
but I mean, jokes aside, the bigger problem in the US is people are sending their DNA samples to ancestry.com. And what's happening is, so you send your sample to check your ancestry, and everybody likes it in the US, and they send it. And what these people do is, though, they have this huge collection of millions of DNA samples, wherein they just look at ancestry and say, oh, you are half British, half Norwegian, half African, or whatever, or quarter. Now what's happening is the police are coming to them and saying, we need to look into your data. And they are identifying all their cold cases. So they've got the classic example, you can Google it, the Golden State Killer. So people have not given their consent for police to check that, but the police have come in. Now they've got a distant relative. So one person sent for ancestry. They got a sample, the Golden State Killer was a murderer. They got a sample somewhere, but they couldn't match anybody. They ran the sample against every sample in ancestry.com and found that this was a relative of that individual. And they tracked it and got the patient. So you cannot escape.
So we've had a wonderful 1.5 hour session. Thank you, Clea, and thank you, Santosh, for taking the time to make the presentations. And thank you, Dr. Shekhar, for joining despite your busy schedule. Thank you, everyone, for those who logged in. And like all of you said, I think pretty soon we'll be seeing pharmacogenomics coming out in a big way in India. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.